Yes, hello everybody. My name is Tyler Lyckberg. I'm a student at Palo Alto University, currently on internship at the Spokane, Washington VA. So this is a largely modified presentation from its original form. Just really wanted to give you guys the nuts and the bolts of a study, of a larger study that I conducted with Dr. Quinn Tiet and Dr. Craig Rosen down in the San Francisco Bay Area at the National Center for PTSD in Menlo Park. So this presentation goes over predictors of veteran hospitalizations for suicide risk within 4 months post-discharge from residential PTSD treatment. So again, just in an effort to be concise, a lot of this is largely modified. So just to give you a quick preface of why this study was important to us, because part of the VA's mission is to really try to better understand and prevent suicide. As you know, the crude rates of veteran suicide are much higher than that among the general population. And a real effort of the Menlo Park VA was to try and identify ways in which technology or apps or even telephone monitoring conditions can support veterans in suicide management. So the rationale and the aims of our study really sought to collect a group of veterans, and we utilized 5 different VAs from across the country to try and track them after they exited inpatient or residential PTSD treatment, because we were interested in following up with what kind of predictors really implicate the propensity for someone to become hospitalized for suicide in that period. So we really aim to see, are there specific risk factors that can give us information in the first 4 months, and can telephone monitoring support as an additional component of aftercare help to reduce suicide hospitalizations. So across our 5 VA different sites, our total participant number was 837. There was about 87% male, 13% female in that distribution. There's a number of exclusion criteria, as you can see here. Basically, if they were discharged from their PTSD treatment too quickly, or if they had something interfering with their ability to follow up. So again, after they had exited their inpatient care, they were placed in one of 2 conditions. So this was an RTC, either standard aftercare or standard aftercare plus that telephone monitoring component. So we were really interested in following up a number of different times. So again, this is just a tidbit of the larger scope of the study, which actually assessed veterans when they were first admitted and enrolled, and then at the time of their discharge. Then we also assessed them with a questionnaire at 4 months out, and then again at 12 months out. This is just going to focus on the first 4 months. As you can see here, there's a good array of variables. These were all measured continuously, with that outcome variable, hospitalizations, measured dichotomously. We are simply interested, did this happen 1 or more times, as opposed to none at all? So our hypotheses were that these variables, which we just mentioned, would somehow predict post-discharge suicidality for hypothesis 1. Our hypothesis 2, we thought that the biweekly telephone monitoring support, basically providing phone calls to veterans, would actually prevent suicide to some degree as well. And for those 2, we used a binary logistic regression, and then we used a chi-square analysis. So as far as the results go, we were actually pretty surprised to find that the only 2 real significant predictors in this population in this study were that quality of life and history of suicidality negatively predicted suicide at that 4-month follow-up time point, right? And then the interesting thing about us assessing this at 4 months, what we know about post-discharge from inpatient care is that the first 3 months are usually the highest risk period for veterans. So we were really curious to see during this time, what are the indicators? And it turns out veteran subjective quality of life and what they perceive to be the home or the place that they're returning to after their care, along with those who had historical suicide attempts before. Surprisingly, with the telephone monitoring condition, there was no significant association between the calls and preventing hospitalizations due to suicidality. So that's an interesting thing to note, because by the numbers, there actually was a lower number of veterans who were hospitalized, but it was not to the degree of that being significant. And one of the potential takeaways there is that actually those who were provided the telephone calls and were encouraged to provide their outpatient appointments might have actually had a closer proximity to being encouraged, right? If they were meeting the degree of risk to be hospitalized, that they were in contact with providers who could make that happen, as opposed to not. So given these findings, there's a couple important takeaways, I think, for the literature, really addressing ways in which that low quality of life can be addressed during any residential PTSD care, as well as followed up on after their discharge. I really think that further research is needed to determine the best use of this telephone monitoring condition, and this remains an aim for the National Center, and really trying to determine what is the population that can benefit most from this condition, and what are the ways that we can really utilize outpatient or aftercare services more appropriately. And the thought is that those with remote access to care might benefit more. So future studies might look at how these risk factors predict specific different kinds of hospitalizations, because we just looked at hospitalizations due to suicidality, but that certainly wouldn't include other types of hospitalizations, including medical reasons or substance use or other things that are closely related with PTSD. I think one of the things I already emphasized is that we would like to try to implement specific interventions both during and after treatment to really address this low quality of life concern. Although it's not outlined in this study here, part of the greater study we did found that aggression was a predictor within 12 months. And we also looked at some significant predictors of dropout. And we found that people who are younger and unmarried and maybe a little bit more likely to be moving around were more likely to drop out from these kinds of studies. So I just for the sake of time, this was all I had to give you a bit of the nuts and the bolts, but I'd love to save the last minute or two for any questions I can try to answer.
Tyler, I have a question.
Yes.
Can you hear me? This is Dr. Casey Ward in Olympia, Washington.
Yes.
So can I ask a few technical questions?
Sure.
So was there a big difference in the age group of the subjects that you used all the way from like, and did you also record how long they had been in service?
Yes. Yes.
Okay.
So there was a pretty bimodal distribution of age. I think the mean was about 49, 50. And we did actually track how long they were in service. We tracked how long their residential care lasted, because there was a pretty significant difference in the different kinds of residential care that some veterans got. It was, just over 15 days, and some folks I think were close to 3 or 4 months. So it did vary. That wasn't part of what we assessed for in this tidbit of the study.
Could I ask another question, Tyler?
Yes, of course.
So the phone interview, did the people get different callers each time, or did they have one assigned to them? And then did they use a protocol in terms of the questions that they asked each time?
Yes.
And were they rated and then adjusted for that?
Yes, that's a really good question. So that is actually part of the limitation of the study is that the intent of those calls was actually just to encourage outpatient visits. It wasn't actually to assess or monitor for any suicide prevention. And so with the callers, there was the same caller for each veteran throughout, but there wasn't necessarily a prescribed protocol other than it being a 5 or 10 minute.
So you didn't use like DBT or any of the?
No, there was no specific type of psychological intervention other than the supportive call itself to encourage outpatient visits.
Were there any completed suicides through your study?
Not to my awareness. It's certainly possible among the dropout participants, but I have not retrospectively gone back to look at any of those records. That would be a really good thing to look at.
And were those people who dropped out, were they given extra care or given like resources if they decided to leave the study? That would have been an indicator to me that maybe they would have been more high risk than the ones you were studying.
Absolutely. And you're right. And so my contribution on this study was assessing this using archival data. So that would be a question probably for Dr. Rosen or Dr. Tiet at the Menlo VA when they did this at the time of the study. But very valid question. Thank you.
Thanks, Tyler, very much.
Okay, so we have a couple of questions here. It looks like David's asked, can you clarify low quality of life a bit more?
Yes. So I didn't have time to go through all the operationalizations for all of these variables. But our quality of life measure, let me see if I can find a quick note on it. The quality of life measure assessed for a number of different factors, kind of a conglomerate assessing for things. It was a short questionnaire on health, work, relationships, living arrangements, how free time is spent, the amount of time spent with other people, the amount of fun experienced, familial dynamics, friendships, financial comfort, and physical and emotional well-being. So that was all sort of condensed right into one composite variable.
Great, good. And the next one we have is from Jennifer. Very interesting. I'm curious if you found any impact on race and socioeconomic status in terms of outcome.
Yeah, good question. So part of the things that we assess for, we're looking at white veterans versus minority veterans. And surprisingly enough, in this study, there were not any significant differences. And SES was something that we considered as well in different status. And I think that was the probably closest we got to, and that was tied into that quality of life variable.
All right. And this looks like this is just a remark from Julia. Tyler, appreciate this reminder that sometimes the best predictor of future behavior is past behavior. And I think I'll second that one as well.
Absolutely. Thank you all for the time.